Hi, my name is Christina Weng. I'm on faculty at the Baylor College of Medicine in Houston, Texas, and I'd like to thank the organizers for the invitation to speak on our teleretinal screening program for diabetic retinopathy. I'd like to acknowledge my co-authors listed below. These are my disclosures, not relevant to this talk. Diabetes has truly reached epidemic proportions. In the US, there are 29 million Americans that have a diagnosis of diabetes. That's almost 10% of the population. And this problem is shared around the globe. 415 million people across the globe have diabetes, and this is projected to grow to 642 million by the year 2040. We know from epidemiologic studies that the majority of these patients will eventually go on to develop some level of diabetic retinopathy. And this is why the American Diabetes Association and the American Academy of Ophthalmology recommend annual dilated examinations for all diabetic patients. Unfortunately, we know that only slightly more than half of these patients are actually compliant with this recommendation. To add to the challenges, demand is outpacing supply. Over the next 15 years, the number of diabetics is projected to increase by 20%, while the number of ophthalmologists is going to increase only by 2%. To address some of these issues, the Harris Health System launched one of the largest teleretinal screening programs in the United States in 2013. And this Harris Health System is a public county health system that covers patients in Southeast Texas, including the city of Houston. This is based on 13 non-mydriatic fundus cameras that are placed at various primary care sites in the health system. So let me take a moment just to walk you through how the teleretinal screening program works from an operational standpoint. So a patient with diabetes comes to see their primary care doctor, whether it's for a sprained ankle or a sore throat, whatever the reason might be. If they haven't received a dilated fundoscopic examination within the past year, they're then whisked away to a different room in the same clinic where they have their fundus photos taken by a trained personnel. Most of the time they actually don't need to be dilated, which is appreciated by most patients. These images are then uploaded to a cloud-based server, and image interpretation occurs virtually, usually within 1 to 3 days. An interpretation is then translated into a recommendation to the patient. And the way we have our thresholds set in our program is that patients with an interpretation of severe non-proliferative diabetic retinopathy or proliferative diabetic retinopathy are referred for an in-clinic examination. The remainder of patients with lesser levels of diabetic retinopathy are asked to return for repeat imaging in 1 year. We've done 81,000 teleretinal imaging screenings to date, and you can see that this number has increased year on year. These have not been done in vain, as pathology has been detected in 43.2% of screenings. Looking more closely at what our primary concern is, diabetic retinopathy. Diabetic retinopathy of any level was diagnosed in 42.2% based on screenings. And looking at the most severe levels of diabetic retinopathy, severe NPDR and PDR, this was found in 4.3% of all screenings. As with any screening program, there's going to be a fraction of those that are false positives. So we looked at the group of patients who had an interpretation of severe NPDR or PDR based on imaging, and we compared that interpretation to what was actually found based on in-clinic examination. And we calculated a positive predictive value of 71.8%. Delving more deeply into the accuracy of diabetic retinopathy grading, you can see that we do overall quite well. 83% of teleretinal imaging reads fell within one diabetic retinopathy severity level of clinical exam diagnosis, and most of those were an exact match. Other benefits that we've gained as a result of the program include an improved annual compliance, which improved from 62 to 80% within our first year. Additionally, ophthalmology clinic wait times decreased in our system from greater than 3 months to less than 1 month, and this was the result, of course, of optimizing those slots for the patients who needed that care most acutely. One of the unfortunate observations that we observed was that only 52.4% of patients who were referred for in-clinic examination actually came. Compliance, however, did increase to 84% amongst those who were asked to return for subsequent visits. I've included some images from the teleretinal screening program below. This is from a 38-year-old working father of 2. Completely asymptomatic, and you can see that based on teleretinal imaging scans, he was found to have advanced proliferative diabetic retinopathy. We brought him in right away, got him treated with pan-retinal photocoagulation laser, and he's doing very well over a year later. He's one of the many examples we see every day of patients who I truly believe have their vision saved as a result of this program. So in conclusion, the Harris Health System teleretinal screening program has significantly increased the rate of annual diabetic retinopathy screening and allowed our clinics to optimize appointment utilization. Teleretinal imaging allows for accurate diabetic retinopathy detection and grading. And of course, compliance is a fundamental element in the success of a teleretinal screening program. And we found that our rates were less than ideal. The silver lining is that there seemed to be a higher compliance rate observed in patients who were asked to return for future visits, suggesting that patient education likely plays an important role, and this is the subject matter of ongoing analysis. Thank you very much.
Yes, please.
Ihab Atman from Cairo, Egypt. We use the wide field opto system in Egypt. And I agree with you that non-dilating fundus patient is in doing fluorescein or taking a picture is definitely something patients really appreciate. So have you looked into the difference between your system and the wide angle in regard to the predictive value and the relevance on that?
It's a great question. I think that, you hit the nail on the head. The DRS cameras that we're using in our program are only 60 degrees, and so you do miss potentially a lot of pathology in the periphery. Unfortunately, because of financial restrictions, this is a publicly funded program. We haven't been able to incorporate the use of wide field imaging, but I do think that, as well as the integration of OCT technology, would really advance the utility of the program, as well as its accuracy.
I agree. Yeah.
Thank you.
Yes, please.
Ahmed Salam from Arkansas. This is a great talk. I think the main problem in the US screening for diabetic retinopathy is that you cannot invite every diabetic patient in the county. I used to work in England and that was the case, and I think that's why screening there is very successful. I don't know, what's your take on this? Is there any way to move that forward?
It's always a challenge because you're absolutely right that we only see what we see. We only see the patients who are captured in the program. What's nice about this particular program is that it's closed. It's a closed system. And so all the patients who have access to care fall within a certain pool. We have seen an increase, as I mentioned, in the compliance rate amongst this pool of 45,000 diabetic patients in the Harris Health County. But you're right, we're always striving to gain more.
Thank you, and I think we have to move to the...
Okay, Rahila Zakir, UK, London. We have the English National Screening Programme in the UK, and we have a lot of levels of screening and grading in terms of confirming intergrader reliability and intragrader reliability. And what we also find, because we manipulate the images when we're screening and grading, we can actually see a lot of pathology that you can't see clinically with the naked eye at the slit lamp. So I would always take the image or the grade that was diagnosed by the grader from a manipulated image over and above what the clinical finding was.
It's an interesting point, and we've used papers from your system, I think they're a great model for teleretinal screening as a whole. We also have manipulative software, I just didn't have time to get into it, with our images, and you're absolutely right that sometimes it does highlight things that you don't see otherwise. For the sake of calculations for this study, we use the clinical examination as the gold standard, as is used widely for many studies. But I think that you make a really good point in that there might, the clinical examination is definitely not perfect, and there might be enhancements through other images, through other imaging modalities that allow us to see more.